Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot, and we're going to be covering maternity and peds, disorders that we see in pediatrics and maternity/OB. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking the video. You're going to love it. Go ahead and give it a thumbs up now so you don't forget. Subscribe to my channel if you haven't done so already, and be sure to check out my website, www.nexusnursinginstitute.com. There you can sign up for next generation NCLEX review session, part 1 and part 2. In part 1, I teach you how to think critically. I teach you about the most common and important scenarios that NCLEX will put you into and where your mind is supposed to go. I teach you about common phrases that are used and how you're supposed to think. I teach you about priority. I teach you about delegation. In part 2, we go over NCLEX type of questions, rationales, and important concepts you need to keep in mind regarding those rationales, because you're not going to get the exact question, but you may get something similar, and you have to understand where the test writers are going. If you're currently in the program and you have to do really, really well on your next exam to pass, I suggest you check out my audio lessons. I have audio lessons available. See if I have something that matches your next exam. And for the students who may just want to pick my brain about something, you want some advice about something that has to do with the arena of nursing, or maybe you want some private tutoring sessions, you can sign up for a one-on-one private tutoring session or a consultation session with me at my website, again, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, such as TikTok, Instagram, Facebook, and right here on YouTube. My handle's the same everywhere, Nexus Nursing. Now, without any further ado, guys, let's get started. Maternity and peds. First question. So your patient is 36 weeks pregnant, gestation. She's complaining of a headache, blurry vision, swelling of her hands and face. What is going to be your priority action? Is it going to be to check the patient's blood pressure? Is it going to be to administer acetaminophen for the headache? Is it going to be to assess the fetal heart rate? Or are you going to schedule an ultrasound for fetal growth? What is going to be your priority action? Very good. Check the patient's blood pressure. If something's wrong, the first thing you do is get more information. You're going to assess. And sometimes, guys, these test questions is not going to be that easy where you just assess your patient. Remember, there are more than one way to get information. Yes, assessing, doing physical examination on your patient, but how else can you get information? By asking a question, by looking at labs, looking at vitals, going into the patient's chart, right? Anything that you do to get information is a form of assessment. When something's wrong, you want to get information, you want to assess. Now, let's look at the wrong answer choices. Administer acetaminophen for the headache. If you choose this, you're letting the test writer know that you don't understand what complication may be happening here and what's likely. Guys, what do you guys suspect as a nurse? If your patient was 36 weeks pregnant, they came in with these symptoms, what would you suspect is happening? What diagnosis would you suspect? Yes, preeclampsia. Okay, so we're not going to try to mask the symptoms. You're not going to choose acetaminophen. We want to make sure that this patient isn't possibly going to go into a hypertensive crisis. We don't want this patient to go from pre-eclampsia to actual eclampsia where the patient's having seizures. Look at the other option, assess fetal heart rate. Again, guys, well, not again, this is the first time I'm telling you this on this live, but I've said it several times before. And this is why I don't really like doing maternity. I haven't liked doing maternity for the past couple of years, because this has only started happening to me the past couple of years, where I will get crazies and they will send me these mean, nasty messages. I'm talking about science, guys. So if you don't like what I'm saying, go get mad at your politician, get mad at Elsevier or Davis or Lippincott, whoever, not me. I didn't make this stuff up. That's why I don't like doing maternity for the past couple of years. It's been a mess. But I'm just telling you this, guys. This is nursing. It's in the textbook. I did not make this up. When it comes to the mommy and the baby, the mother and the fetus, you're always going to assess the mother first. If something's going on with the mother, you're going to assess the mother first. So we're not going to choose assess the fetus where the mother is complaining of the headache. The mother is having the blurred vision. The mother is having the swelling of the hands and feet. Who are we going to assess? The mother. So we're not going to choose that. And last, schedule ultrasound for fetal growth. Well, why would we do that when something's going on with the patient right now? Whenever something is acutely happening with your patient, you want to assess what's happening with your patient right now. Don't be distracted by the answer choices where you're worrying about something later. When you choose that, you're letting the test writer know you're not really a good nurse. You're going to let your patient right there in front of you. Okay, so that's why we're choosing to check the patient's blood pressure. That's right, Francesca. We're worried about the mom, then the baby. Very good. Oh, one more thing I want to bring to your attention. So we suspect that mom is having preeclampsia. This patient's having preeclampsia. You're going to want to decrease stimulation, right? That patient's going to be at the end of the hall, away from the nurse's station, away from the telephone ringing, nurses giving report. Again, you want decreased stimulation. That patient's going to be on seizure precautions. The bed going to be in the lowest position. Side rails are going to be padded. Light is going to be dim. You're not going to have the TV on. You're not going to have the radio on. You want to decrease stimulation for this type of patient. Your patient is in labor. The fetal heart rate is 90 beats per minute, and it does not increase with contractions. What is your priority nursing action? Is it to notify the health care provider? Are you going to reposition the patient to improve uteral placental circulation? Are you going to administer oxygen via face mask at 10 liters per minute? Or are you going to document the findings and continue to monitor? No, Noah, we're not at max sulfate. The patient is in preeclampsia. Too soon. Okay, so to answer this question, guys, we're going to reposition the patient to improve uteroplacental perfusion. We're going to turn this patient because look at what's happening. Look at the fetal heart rate, 90 beats per minute. What are we seeing? Bradycardia. Okay, and bradycardia can cause fetal distress. So we're going to reposition. We want to relieve cord compression if that's the issue, and we want to increase oxygenation. All right. Now let's look at the wrong answer choices. Notify the healthcare provider. I'm not saying that's never the answer, but before you choose that as an answer choice, you better look at your other options and just confirm that you can't do any of those for your patient before you turn your back to call the healthcare provider. Usually, there's at least one thing you can do for your patient before you pick up the phone and call the healthcare provider. Why? Because you're testing for your nursing license. We know the doctor knows what to do. The nurse practitioner knows what to do. The physical physician assistant, they know what to do. They got their license. You're trying to get your license. So they're trying to see, do you know what to do? Okay. Next, administer oxygen via mask at 10 liters. Giving oxygen, that would be after you reposition because the problem isn't oxygen, right? The oxygen is in the hemoglobin that's in the RBC that's in the blood. The problem is most likely cord compression. So that's why you're going to reposition. And you see that last option, 10 of you guys chose document the findings and continue to monitor. The only time you document findings is when nothing's wrong. If everything is perfect, that's when you document and you continue to monitor. But whenever something is acutely wrong, something's happening right now, you're taking action, you're not documenting. And at 90 beats per minute, that's bradycardia, which can lead to what? Fetal distress. Okay? For the student that asked why seizure precautions, when you're in preeclampsia, you're at risk for going into eclampsia and actually having seizures. We don't know when it's going to happen. So that's why seizure precautions are in place. And this patient is exhibiting signs of preeclampsia. The question was about that first slide that we just did, guys. Third question. So your patient is 2 hours postpartum. The uterus is firm and midline, but the patient has saturated 2 pads within 30 minutes. What is your priority action? Are you going to document the findings and reassess the patient in 15 minutes? Are you going to perform a fundal massage to stop the bleeding? Are you going to assess the patient's vital signs and call the healthcare provider? Or are you going to check for signs of retained placental fragments? Okay, you guys are all over the place on the live. Wow. This is the second time I'm doing this Kahoot. We did this yesterday, but I forgot to record, so I'm doing it again. And once again, most of you guys chose the wrong answer. You saw fundal massage and you ran right to it. Go back to the question. It's 2 hours postpartum. The uterus is what? Firm. Why are we massaging the fundus? It's firm. So yes, this patient is bleeding out because they're saturating 2 pads in 30 minutes. That's way, 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 way too much, right? So yes, they're bleeding out, but they're most likely not bleeding out from the uterus being soft and boggy because the question says it's what? It's firm. Guys, don't let your brain fill in the gaps for you. Read, right? Don't just jump to massage the fundus. You massage the fundus when it's soft. And that's what's causing the bleeding, or that's what could cause the bleeding, but not in this situation. That uterus is firm and it's midline. What does that tell us when the uterus is midline? Most likely, the bladder's not full, because when the uterus is off to the side, the patient's bladder's full and you have to have that patient urinate. But that's not the problem either. It's midline. So what are we going to do? Assess, get information. You're going to assess the patient's vital and call the healthcare provider. Because we're seeing saturation of 2 pads within 30 minutes. We suspect that this patient's bleeding out. We're going to take those vitals. And if that patient's bleeding out, blood pressure is going to be down. Urine output is going to be down. Heart rate is going to be up, right? We're going to be looking for those signs and symptoms, and we're going to notify the healthcare provider. So you're not going to document the findings and reassess the patient in 15 minutes. If you chose that, I'm happy nobody chose it, because you understood something was wrong. So nobody chose that. Good job. And the other option of check for signs of retained placental fragments. Yes, retained placental fragments, that can be a cause of bleeding. Absolutely. But that's not the first thing you're going to do. When you're asked for a priority action, that means you can only do one thing. Why would you choose that over assessing your patient, getting information? Does that make sense, guys? Yeah, the patient's at risk for hypovolemic shock. Exactly. Which of the following statements indicates a need for further teaching about the evacuation of a hydatidiform mole? I need to avoid becoming pregnant for at least a year. I will have my HCG levels checked regularly after this procedure. It's normal to have a small amount of spotting for a few weeks. Or if I feel ready, I can start trying to get pregnant again in 3 months. Very good. If I feel ready, I can start trying to get pregnant again in 3 months. Absolutely not. That requires further teaching, because a client who's had an evacuation of a hydatidiform mole, and that's going to have to be evacuated, okay? They should not get pregnant for a year. Now let's talk about hydatidiform mole. Hydatidiform mole is a cluster of pregnancy-related cells. It is not a pregnancy. It's just a cluster of pregnancy-related cells. It is not viable. It has no organs. There is no heart. There's no liver. There's no spleen. There's no eyeballs. There is nothing. It is a clump. They look like little grapes. It is a clump of pregnancy-related cells. Again, don't come after me in the messages, because I'm going to start popping off on you guys. I've had it up to here. I'm just trying to teach nursing students. That is it. It's a cluster of pregnancy-related hormones, cells, excuse me, not hormones, cells. And so this person, this person that has it, their HCG levels are going to be high. And so what happens is after the evacuation, they're going to have to come in about every week to get the HCG levels checked. And like I said, they're going to be high. And every week we expect to go lower and lower and lower. And they're going to keep coming in. So for follow-up until, it's at the normal level. Usually it takes about 3 weeks, but everybody's different. But that's around the time frame. Okay, but it is not viable. So saying I need to avoid becoming pregnant for at least a year, that's good. That doesn't require further teaching, so we're not going to choose that. Correct. False pregnancy, because it's not a true pregnancy. It's not a true fetus. Next, I will have my HCG levels checked regularly after this procedure. That is true. They're going to have to come in every week for follow-ups. True. It's normal to have a small amount of spotting for a few weeks. That is true. Something else you guys need to know, because that may also be a test question. The spotting is not going to be bright red, right? You know how in a normal viable pregnancy, you have that active bleeding, you're going to see bright red. No, and this is going to be dark, like purple, brown, almost even black, very, very dark color, okay? All right, type in your answer. Your patient is 36 weeks gestation and they come to the ER with severe abdominal pain, vaginal bleeding, and uterine tenderness. What do you suspect is happening here? What do you think this patient's going to be diagnosed with? If you guys are not part of the Kahoot, let me know on the live. What do you think's happening here? Very good. And you know what? I'm sorry to Evolve and Elsevier or Davis. I didn't mean it. I didn't tell you to go complain to them. That was just my annoyance. Don't go complain to those people. They didn't make up the science either. Okay, yes, placental abruption. Very good. Very good. That's what's happening. Placental abruption. What we're seeing here, guys, is that placenta has done what? It's detached. Very good. From the uterus. Those are the classic signs and symptoms. Okay. The woman that's pregnant and she's having severe abdominal pain, vaginal bleeding, uterine tenderness, that's what you should suspect. And also, guys, this is a medical emergency. Place the following interventions in order of priority for placental abruption. Here are your options. Administer oxygen via face mask. Monitor maternal vital signs and fetal heart rate. Position the patient in the lateral position to optimize perfusion. Establish and maintain IV access with a large bore needle. So these are your 4 options. Take your mouse and put it in the correct order of priority. What are you going to do? First, second, third, and fourth. Gent Rose, thank you for sharing the live. Thank you. Okay, only 9 people got this right. The first thing you're going to want to do is position the patient in lateral position to optimize perfusion. You want to increase blood flow and decrease that pressure on the vena cava. That's going to immediately increase perfusion. So that's the first thing you want to do. After you perform that nursing intervention, what does the nursing process tell us? We have to evaluate, see if it worked. So what are you going to do? Vital signs, monitor the vital signs and the fetal heart rate. Monitor. In order to monitor something, monitoring something is ongoing. You had to have done something before you monitor. So monitor couldn't have been first. You had to perform a nursing intervention. So anyway, you monitor vital signs. Then you can give the patient oxygen. Okay? Because I know you guys always want to put oxygen first, but it has to make sense. In placental abruption, is oxygen really the problem? No, it's perfusion. So you want to correct the perfusion first. You correct the perfusion, then you evaluate your nursing intervention, then you can give them the oxygen, and last, establish and maintain IV access. Why? You expect to give this patient IV fluids. You expect most likely to be giving this patient blood. And the last thing you're going to do after you've done all these nursing interventions is call the healthcare provider to see if there are any other orders or anything else that needs to be performed, and to let them know of the patient's status after these nursing interventions have been performed. Okay, your 6-year-old patient has tonsillitis. So now we're switching gears. We're talking about pediatric patients now. You would teach the parents to seek immediate help in which situation? Difficulty swallowing and drooling, low-grade fever and fatigue, mild throat pain and hoarseness, or intermittent earache and nasal congestion. Very good. Difficulty swallowing and drooling. So what are we concerned about? Airway obstruction. And another classic symptom that you may see, if it's a select all, make sure you choose it, stridor. You hear stridor, that's a medical emergency. Their airway is literally closing up on them. Tonsillitis, that's infection and inflammation of what? The tonsils. So we're going to be concerned about those symptoms of airway obstruction, because airway obstruction is a lethal complication, possible complication of tonsillitis. Now look at the other options: low-grade fever and fatigue, mild throat pain and hoarseness, intermittent earache and nasal congestion. These are associated symptoms of that disorder. We don't like it, but it's not a priority when you compare it to the complication of airway obstruction. So that's why we went with difficulty swallowing, drooling. And of course, if you see stridor, you better choose that as an answer first. Because let me tell you something, stridor trumps the difficulty swallowing and the drooling, actually. If you had to go in order of priority, it would be the stridor, drooling, then the difficulty swallowing. I'm just saying. You're caring for a newborn who's diagnosed with Hirschsprung's disease. Which of the following findings would you expect to find? Is it ribbon-like stools and abdominal distension? Would it be frequent stools and hyperactive bowel sounds? Would it be projectile vomiting and failure to thrive? Or would it be blood-streaked stools and severe rectal pain? Very good. Ribbon-like stools and abdominal distension. So let's talk about this disorder, Hirschsprung's disease. This is where the patient has agangliotic cells. No gangliotic cells. That word A in front of a word means without in the medical field, right? Right. So no gangliotic cells in the large intestine, to be more specific, like in the rectal area. So what happens is that sphincter that is supposed to open up so, the fecal matter can go through, it's not loosening up. So you have all this fecal matter, it's building up and building up and building up because it can't get through because the sphincter is not opening up, right? It's only opening up just a tiny little bit. And so that little bit of fecal matter that does squeeze through that sphincter, it comes out looking ribbon-like because it was such a tiny area to squeeze through. And of course, that patient's going to have abdominal distension because you have all this fecal matter that's just building up because it can't go anywhere. That sphincter is not relaxing for that fecal matter to get through. Now let's look at the other options. Frequent loose stools and hyperactive bowel sounds. Where would we see this? We would see this in disorders like diarrhea, gastric enteritis. How about projectile vomiting and failure to thrive? What disorder would that be? Pyloric stenosis. Very good. And last, blood-streaked stool, severe rectal pain. We see that in a patient that has something like anal fissures. Okay, you guys do have to know all those disorders that I just mentioned, besides the Hirschsprungs. You have to know them. You got to know those clinical manifestations and the nursing interventions. Don't say I didn't warn you. Don't shoot the messenger. All right, a 2-month-old infant is diagnosed with coarctation of the aorta. Excuse me. Which of the following findings would you expect? Would it be bounding pulses in the upper extremities and weak pulses in the lower extremities? Would it be cyanosis and clubbing of the fingers and toes? Would it be continuous murmur that radiates to the back? Or would it be poor feeding and episodes of diaphoresis during crying? Oh my gosh, I need to get glasses. I can't see. Very good. Pulses in the upper extremity are going to be strong and bounding, while the lower extremity is going to be weak. Okay, why? Let's talk about coarctation of the aorta. This is a narrowing near the ductus arteriosus, and that's what causes the strong bounding pulses in the head and the arms, but yet diminished weak pulses in the legs, the body, and the lower extremities. Okay, now let's look at our other options. Cyanosis and clubbing of the fingers and toes. 9 of you guys chose this, and that we see in cyanotic defects. By the way, guys, you guys have to know the difference between the cyanotic versus the acyanotic cardiac defects, and you guys have to know what disorders fall under each. I'm just telling you now. But anyway, the cyanosis and clubbing of the fingers, we see that more in the cyanotic defects like tricuspid atresia or oh my gosh, what's that other cyanotic defect? Something of Fallot. I'm having a brain fart. What's the word I'm looking for? Something Fallot. Thank you, tetralogy. Tetralogy of Fallot. So those are like cyanotic defects. That's where we would see like the cyanosis and the clubbing of the fingers and toes. Next, 4 people chose continuous murmur that radiates to the back. We would see that in patent ductus arteriosus. And last, poor feeding and episodes of diaphoresis during a crying. We see that in a variety of congenital cardiac defects. That's really not specific to any one congenital heart defect, like our answer here. Strong pulses in upper extremities, weak and lower, immediately you need to be thinking of coarctation of the aorta. So make sure you guys know coarctation of the aorta, but make sure you guys know about all of the other disorders that I just mentioned, because I don't write your test. I don't know which one you're going to get, but all of those are important ones to know. Okay, your 10-year-old patient with sickle cell disorder is in vaso-occlusive crisis. Which intervention would you prioritize? Would it be to give oxygen as prescribed? Would it be to initiate IV fluids and maintain hydration? Would it be to provide a high-calorie, high-protein diet? Or would it be to administer antibiotics to prevent infection? What's going to be your priority? Very good. IV fluids. IV fluids. I'm very happy that you guys didn't do like yesterday, because I started yelling when you guys all wanted to go with oxygen. Fluids. This patient is in vaso-occlusive crisis, which means all those RBCs have now turned to sickle shape. They have now started to clump together. They have now turned the blood very thick, so it's very hard for there to be circulation. This patient's at risk for blood clots. What is the fastest way to resolve this problem? IV fluids. The minute you give that patient fluids, those sickled shaped cells turn back into the disc shaped cells. They stop clumping together. That blood stops being so thick, and the blood can what? Move freely through the vessel. So we want to get rid of that viscosity and the sickling. Very good. Now, after you give that patient hydration, feel free, go ahead, give them oxygen. But at the end of the day, oxygen was never the problem. The oxygen was already in the hemoglobin, that was already in the RBC, that was already in the blood. The problem was that blood wasn't going anywhere. So those tissues and cells couldn't be perfused. Okay? Very good. Your 4-year-old patient is diagnosed with a Wilms tumor. Which of the following nursing action is most important in the preoperative period? Would it be to teach the parents about post-surgical chemo? Would it be to monitor the child's urine output and abdominal girth? Would it be to avoid palpating the abdomen during assessments? Or would it be to encourage the child to increase fluid intake? What do you guys think? Very good. Avoid palpating the abdomen during assessments. So why is that so important? Wilms tumor, this is a tumor of the kidney. This is the most common tumor or tumor of the kidney that we find in pediatrics. This type of tumor is very, very, very vascular. So what you don't want to do is palpate the abdomen and accidentally rupture that tumor and spread those cancer cells throughout the patient's body. Okay? All right. Last question. You're caring for a 5-year-old admitted with bacterial meningitis. Which of the following nursing interventions is a priority to implement? Would it be initiate isolation precautions? Would it be to administer prescribed antibiotics? Would it be to monitor the child's neurological status? Or would it be to obtain a blood sample for culture and sensitivity? Remember, whenever you're being asked about a priority, that means if you can only do one thing, what would it be? What is the first thing you're going to do? The most important thing to do. Very good. Initiate isolation precautions. And guess what? You're not going to wait until the patient's been officially diagnosed with meningitis, because remember, we got to do a culture. It takes a couple days for the results to come in, right? You just have to suspect it. So usually what NCLEX will do, or the test writer, if you're currently in the nursing program right now, they won't even mention the word meningitis. They will give you the risk factors and the signs and symptoms. So they'll tell you it's either a young child or an older adolescent or young adult. They'll tell you that they are in the Army or the Navy or, some type of armed forces barracks or maybe a prison or dormitory, anywhere where there's a lot of people in a very small space, right? And the patient presents with fever, headache, change in level of consciousness, mucorigidity, photophobia, classic symptoms. They will give you the classic symptoms that your mind should go to meningitis. The minute you suspect meningitis, immediately the first thing you're going to do is put that patient in isolation. Immediately, okay? That patient's going to be on droplet precautions. They're going to be in isolation. After you've put them in isolation, because remember, you have to protect the public. Okay. After that patient's in isolation, then immediately after isolation, you're going to get blood sample for culture and sensitivity. Immediately after you draw the blood, you're going to give that patient antibiotics. We're not going to wait for the culture to come back, because it takes a couple days and time is of the essence, right? If we wait, the patient can. So immediately after we draw the labs for the culture, we're going to give the patient antibiotics. And then when the results come back and we find out what the patient's sensitive to, then, the antibiotics that the patient's on most likely is going to change. But in that order: isolation, culture, antibiotics. Okay? Yes, droplet precautions. Correct. And guys, that is it for this Kahoot. I'm so happy I did not forget to record this time. Let me know what you thought about this Kahoot. Let me know if you'd like to see more pediatric or OB disorders, I don't mind doing another Kahoot, or maybe you like it in a lecture format or in a Q&A format. Let me know in the comment section. For you guys that are on the live and participated in this Kahoot, let's see how you did.